Thank you, Gayatri.
Thank you.
We thank We Care, the Endocrine Society of India, and the Maharashtra Society for having us here this morning. So we will be talking on a very informal session, sort of a dialogue between us on transgender care. We have some important questions that we're going to answer, and if you have anything that you would like to, ask us, or any experience that you would like to share, please do the same. Thank you. So we have no conflict of interest for this talk. Both of us do transgender care. So I think Suja has about 600 patients who are transitioning under her care, correct?
Yes.
I have about 350 patients to 400 patients who are in different phases of transition in Chennai. Both of us are in private practice. So we do run our transgender setup from our private setup, from our clinic and a corporate hospital, where we do collaborate with the other departments like plastic surgery, dermatology, fertility preservation with gynecologists. So we do this from a private setting from Chennai and Kerala.
So it might be slightly different from the government sector because setting up a clinic is totally different while we are doing it in the private sector. So we will have a discussion on it as we progress. I think we'll start.
Yeah,
right?
Absolutely.
Yeah.
So we don't have any conflict of interest for this presentation for this morning.
And just one thing, that science is dynamic, and what we are practicing today is based on the current guidelines.
So we do follow the WPATH guidelines. We have an Endocrine Society guideline, and we also have an Indian guideline from IdeaCon, the Kolkata. So we do have guidelines in place which help us deciding what treatment to use and how to transition in care. So that's probably you also use, right?
Because yes, same. Early time in our career when we started this, like Sruti started it around 11 years back, right? I started it around 7 years back. So at that point of time, we had only WPATH guidelines to base our practice on. Later on, we formulated this IPATH guidelines. The SAPO guidelines from Kolkata were there. That was the only Indian guideline which was consensus which was available. Later on, the IDEA consensus came. So it's mostly by experience sharing that we learnt. And from treating, from patients, we learnt it, most of it. And now we have all these guidelines to base our practice upon. So,
Most of the learning happened from patients, to be very honest.
Yeah.
Of course, we do have guidelines. Patients teach us a lot. I think not just in transgender care, I think that's true in everything.
True.
But that's how we learnt, and that's how we've been practicing for the past few years and having these transgender setup. So my first very simple question is, I know Mohan also talked about this. How do you address your transgender patients? How do you start this conversation?
Yeah, so early in my career even I was confused. Like the most important thing that I learned over these years is the other person's gender is not what you decide, or it's you cannot assume one's gender by just seeing them, what they are wearing, or depending on their name. You can't just assume. I have done a lot of mistakes. Like sometimes I have assumed the gender. Sometimes I have misused the pronouns. Similarly, even after they have made it like identified themselves as some other gender, in between I might use the opposite pronouns. So over time I have learned from my mistakes, and what I learned is you can just apologize and you can use the right pronoun. So the best, what I usually do is, if it is not clear from their name or like their appearance, I always ask them. A simple question would do, like, what would you like to be referred to, or what is your preferred name, or what is your pronoun? Most of them will give you the perfect answer, and you can follow that. Once they identify as one gender, you have to respect it. You continue addressing by that name. Most of them won't have any documents to support. Like they might be having the name, Aadhaar card in the opposite name, their assigned name, or they might not be having the gender. So in my practice, I had to, because it's a private sector, starting from that registration desk, I had to conduct several classes to my the whole hospital staff, because it's not just necessarily me who is addressing them. Starting from that security staff to every person in my hospital, they should also learn to use proper pronouns and address them respectfully. So that was one thing I did. Then dead naming is one thing which they hate. That is using their assigned name. So even though if they don't have documents to support their preferred name, it is always better to use their preferred name. They call it dead naming if you refer them by their assigned name, and never use these words like when you were real women, or like that words natural, real, all these are kind of derogatory to them. And another thing that is the word, see, they are human beings. That is what I learned over these years. You just treat them respectfully, just like the way you want yourself to be treated. So, referring to them as just mere transgenders, that is disrespectful. So, it's always better to use the like something transgender individual or transgender community. Always refer to them like that. So, yeah, I might
Those
have
are
missed out.
very valid points. Similarly as you said, some people would just say, call me this.
Yeah.
Well, that could be non-binary people as well. They
Yes.
would be neither he or she. They don't have any pronoun. They would say, just call me XYZ.
Yeah.
Right? So you just go by whatever they want. I think the best thing, as you said, is just asking them.
Asking them is that's the easiest way out.
Yeah, absolutely true. Right. I have made a lot of mistakes
Yeah.
too. This he mistakes always happen.
Been
And
there,
what you
done
said,
that.
right?
Yeah.
Apologizing. I think that's the best thing to do. Just say sorry.
Yeah.
And then just you can. And they do also respect when you say apologize and
Definitely.
just pick up the conversation from where you left. Right. So that's the thing that I learned interacting with them, and that's sort of helpful
Yeah.
for almost all the other endocrine management.
Even some of those negative facial expressions that
Right.
initially when I started this clinic, many clients used to complain about the negative facial expression of the staff. That is very important. So I had to take several sessions for these people. And see, this destigmatizing doesn't happen over a day or month. It takes time. So only their visibility and interaction with them will lead on to destigmatization. That is very important.
Brilliant.
Yeah.
It's amazing. So we do have some common terminologies. We're not going to walk you through this because Mohan had already pointed
Yeah.
out these in a session.
Okay, so
It's not moving. Did somebody else move?
yeah,
Yeah.
the previous one. Yeah, so
Yeah. So we'll just move on to this.
this is see, once they come and tell you that they are gender incongruent, the latest ICD 11 guidelines ask you to refer this gender dysphoria, renamed it to gender incongruence, to remove that stigma from the word disease or disorder. Okay, so we all know that mental health psychiatrist or psychologist is very important in this decision making. So how do you confirm or identify your client has dysphoria and that you can proceed with the treatment? Are there any cues to that?
I think the first 5 to 10 minutes of interaction with them, Mohan showed this powerful slide of a boy looking into the mirror,
Yes.
and he's actually seeing himself as a she, right?
Yeah.
So I think that sort of conversation you can pick up from, how long have this in process, and how long have you been socially transitioning, like coming in with this, boys' clothes or wearing the women's clothes when they come to clinic. So you probably can just talk to them and see
Yeah.
how long has this been going on, and they would say, I've been like this forever.
Exactly, the real life
Yeah,
experience.
it's a real life experience. They would have socially transformed for a very long time. Right? So
Yeah.
I think that sort of conversation would really help us, that this is just not body dysmorphic disorder.
Exactly.
Right? It's just not coming up, or it's not, a lesbian or a gay relationship. They are not just trying to transition because their sexual
their
attraction
partner,
is
yeah.
different from the gender identity, right? I think that sort of information that you'd get with the first 5-10 minutes of your interaction with your patient, you don't really need to even go to the physical examination part.
No,
Just by talking to them, you know.
exactly.
You don't need
I
anything
don't
there.
do the physical examination part
Right.
unless I suspect some DSD or something from the history. Otherwise, we don't usually do the physical examination. And their consent is very important. If at all, if you have to do a physical examination, getting consent is very important.
I do the same as well.
Yeah.
Just by talking to them, you know that this is not just something
A
that,
phase or something,
right?
you know.
Phase or a craze.
Exactly.
Is what Mohan used in one of his slide. It's probably not that.
Yeah, because-
they are committed to this, and this is how
Exactly.
they've been, and that sort of a thing you will get. So usually we do have the guideline to send them to a trained mental health professional, but most of the countries, like including United States where I trained, a physician or a family physician or an endocrinologist can assist them and start them on a hormone therapy. right? But the reason why we send them to a mental health professional, the gender incongruence, gender dysphoria is a wrong word to use, as you said. It's not dysphoria. These are not people with no mental health problem or endocrine related issues. So gender incongruence can be picked up by the physician or a family physician, or if you are the primary care physician, you could pick this up. But the reason why we need a mental health professional is a lot of these patients go through depression, anxiety, suicidal ideation, substance abuse,
Yeah.
right?
At
Lot
least-
of substance abuse.
Yeah, compared to the general population, at least more than around 30%, 30 to 35% increased prevalence of all these disorders. And I have at least 50% of these people in my practice, they have a history of attempted self-harm. At least once in their lifetime. Most of them, if you go deep into their history and if they open up, they will definitely give you this history. May not be intended to die or something, but at least to scare or something, they have done it. So, and body dysmorphic disorders, borderline personality, very, very common, very prevalent in these.
So that's where we need the mental health professional help.
Definitely.
Right? So I think that is one reason why we definitely need a
Yeah.
team which includes a psychiatrist and a therapist. But the diagnosis of gender incongruence is done by us. We can diagnose that. We don't need a mental health professional to say that this is gender incongruence. That is our history taking and how we
Yes.
interact with the patient. Don't you agree with that?
Yes, definitely. But being a protocol-based practice and all, and guideline practice, so it is to be on the safer side of the legal side. It is always better to get a mental health professional clearance. So in my practice, I always refer them to my psychiatrist, and they do counselings, and moreover, they prepare them to what is lying. This is not for few months. It is a lifelong therapy. So they have to get prepared for it, because suddenly when you start hormones, I have seen people putting them on testosterone. Suddenly the irritability increases.
Right.
Some people get addicted to some behaviors. So all these, they have to have this counseling sessions, and many people see this as a gateway. Like once I get the clearance, okay, that's done. They don't go to psychiatrist after this. So initially itself, I compel them that, see, this is going to be a lifelong relationship with your psychiatrist. You have to go and get these counseling sessions repeatedly. So that is also very important.
I 100% agree with you on this. So I also refer all my patients
Yes.
to a trained mental health professional, even though I can diagnose this.
Yeah.
But for the exact reason that you said, for aggression, rage,
Exactly.
irritability, substance abuse, a lot of different things. So
And I also document it. I get it clear, that psychiatric clearance, I get it documented.
yeah, absolutely. You need to document that as well. And this is a criteria for establishing that a patient is transgender or gender incongruent is the right word. As you said, DST has to be ruled out, and the patient should have the capacity to make decisions. And potential confounding mental health conditions like body dysmorphic disorder, borderline personality, or just could be a sexual orientation.
Yes.
Has to be ruled out and has to be addressed, and that's where we really need the help of. And if you have children, I don't see that many children or adolescent, you definitely need a trained pediatric mental health professional
Yes.
as well.
Adolescents, I have at least 5 or 6 adolescents under my follow-up. So we don't initiate sex steroid therapy in these adolescents. Only thing that is required is after counseling sessions, and if they clear, the mental health professional clear it, we can go ahead with the pubertal suppression with
Parental consent.
guardian parental consent. And that, because in our country 18 years is the age of consent, so before that it is better not to subject them for sex steroid therapy, because we never know this persisters versus desisters. Even though the number is very small, it is better to give them time to make their own decisions until they are 18 years old.
Perfect, yeah, I agree with that as
Yeah.
well. So these are the Indian guidelines, as you said, the Indian Idea Group Consensus Guidelines. They also recommend to seek help from mental health professionals
Yes.
to confirm the diagnosis. And Endocrine Society also says the same thing, that it's patients do have an underlying psychiatric comorbidities, so they would be required to have a psychiatric assessment and a therapist consult before we initiate them on therapy. So what is your take on this, Suja? Treat after open discussion. Like some of my patients, for example, they want only name change.
Yes.
They're happy with that. Call me XYZ, I'm fine. I don't need hormones, I don't need surgery.
Yeah.
I don't need anything.
Yes.
Just leave me like that. Some of them would only prefer surgery but not the hormones. So what would you do in your practice when your patients say that this is what I want out of treatment?
Yes.
So what would you do?
So, see, one thing is whether they want the change, I mean, physical change. That is one thing. Some need only social change, as she rightly pointed out. So, a little bit of counseling and helping them in getting all these documents corrected. That's all they want. Some people want a physical change, but not. They don't want to go into surgical changes. So, the level of change is totally up to them. Like they have to decide what level of change they want. Usually trans women, like most of them, not everyone, they want complete, they look for, seek complete physical and surgical changes, whereas trans men, most of them want only the hormonal changes and maybe a breast reduction. The down surgeries, most of them may not opt. There are some people, so that is up to them, totally up to them to decide. So initially itself, in the initial conversations itself, we will ask them what is that they want. Like, see, unrealistic expectations are one very common problem with transgender affirmative therapies, because the timeline of changes are not clear with them. They think that they will get the same changes as their peers, and they tend to take over the counter or they take additional overdosed hormones. Like they think that if they take 6 milligram of Progenova, they will get the changes faster. So, and not all transgender people require these any kind of affirmation as well, because they may not be having dysphoria in them. So only if that dysphoria is there, that intense distress of being in the opposite body is there, then only you need to address these changes. So definitely it's up to them. I to have an open conversation with them, try to understand what they want and try to make them understand what I can offer, because I always give them the timeline of changes. This is what happens when you take. And even like for a male trans man, they all think that as soon as they start taking testosterone, they will have secondary amenorrhea, they will get facial hairs. So facial hairs is something we can't predict at all. Some may have it in 3 months, some may not develop it after 2 years. So that all those changes we tell them initially itself, so that they don't have these unrealistic expectations. And regarding surgery also, we never push them into any kind of surgeries. It is when they ask for it, we give them the details regarding all these and give them the appropriate timelines when they can do it.
So in my trans men practice, people of transition, I think when I did my analysis, I've seen about almost 99% have had a mastectomy done.
Yes.
Top surgery. In their word, it's called top surgery and bottom surgery. So top surgery, mastectomy, because there's a lot of social discrimination.
Yes.
At workplace, they're not treated well and all. So most of them have the top surgery, but only 20 to 30% have had a hysterectomy and a
I
hysterectomy
think
done.
it's even lesser in my practice.
Your practice. But it's important to note that down, because we are probably not that old in our practice, but when we get old, we need to do a age appropriate cancer screening for them. Not that testosterone is going to increase the risk of cancer, but we need to know what sort of anatomical parts is left behind. So that we do a age appropriate
age and gender
screening.
appropriate cancer screening. So long term screening is very important. We'll come to that.
We'll come to that. Yeah. So what is conversion therapy?
Yeah.
Transgender?
I think Mohan discussed it.
Yeah, Mohan did discuss this on conversion therapy.
Yeah, this is the most common request that we get from parents. They bring their kids or even adults also, do something. Doctor, you can give him hormones or whatever you want. Give the child back to me as he or she was born. That is the most common. And in our part of in Kerala, what they do is many religious centers are there where they practice this conversion type of treatment. They don't call it conversion, but they assure that we will give back them as they were born. And also another kind of conversion therapy is marriage, what they do in Kerala. I don't know how it helps. They get them married thinking that this is a phase and it will change once they get married. And a lot of others. There are even, I wouldn't say, because conversion therapy is illegal. In Kerala, there were doctors who were giving testosterone to trans men, trans women, thinking that increasing testosterone would convert them back to their male sex.
The same is true with estrogen as well.
Yeah.
They put them on estrogen thinking that they would not change. But that's completely not acceptable. And I think the law first came out from Tamil Nadu. The Madras High Court was the first to say that conversion therapy, like bringing them back to the parents,
Social Justice Board in Kerala also has said the same, and even Indian laws,
Indian
NMC
laws
also
have now
has
said
told
that
it.
conversion therapy will be punished. The doctors who do conversion therapy will be punished.
Yes.
So it's no longer done in Tamil Nadu, and I'm sure in the other states
all
as
over
well.
India also.
Yeah.
Yes.
Yeah. So that's not allowed now. We have a strict law against that. That we're not allowed to convert them back to whatever sex they, because they're very clear on this is what they want, and they have very clear treatment goals on what they want to and how they want to transition.
Yes, I have had some sexuality disorder people coming and asking to somehow convert them back, like a gay person coming in, doctor, is there any way that I can go back? Because of social stigma, not because he doesn't want it. It is because of the social stigmatization.
I think Mohan did touch upon this. Have you done any of these things in your practice?
Yes. Structural changes, yes. Because see, first thing is that when I started, I work in a private sector, so I don't have any private practice other than being in the hospital. So I didn't segregate them. I conducted transgender OPDs as regular OPDs. Like I decided initially itself, they will come to my regular OPD. I don't have any separate days, separate timings. So that one thing is, see, tolerance is one thing, and something offering more than tolerance, that is destigmatizing, giving them the visibility. Initial fear was that what will the cisgender people, will they stop coming to my OPD, was one of my concerns initially. But as years, over these 7 years, it took only very few months. People got adapted to it. Now, see, both cisgender, transgender, everybody sit in the same OPD, same waiting room, and all my hospital staff and even the patients they are used to it now. So that is one method of destigmatizing this, giving them more visibility. Second thing is, we had to change all the forms, hospital forms. Like starting from the registration desk form which they fill, we didn't have option for that other or transgender category. It was all male, female. So not just that, admission forms, the surgical consent forms, every form had to be constructed for this purpose. Another change, after 2 years only we could do that, because we didn't have space to construct the restrooms, and now for past 4 years we are having this transgender restrooms. We couldn't make everything unisex restrooms, but we have male, female and unisex as well. And those changes, then classes, the education classes for staff, that was the most difficult part, I would say, was like making other people, the staff,
getting your staff
getting
aligned
used to
with
this. So currently at least average of 10 people come visit our hospital daily. 10 to 12 transgender people will be there. They will be everywhere. So now they are also like, they don't feel any difficulty in accessing healthcare. Because usually what happens is, previously they would have had some bad experience with some medical establishment, and afterwards they will stop going to these for any kind of illnesses, not just transition. They will go for
cough, cold, fever,
and they will go to all these unethical practices and get operated by some quacks. So all kind of surgeries you would have had experience, no?
Yeah. Right. So I think we also pretty much follow the same thing in our private setup. And as you said, we thought of having a separate clinic, but then we decided, I completely hear what you say in terms of having this sort of no separate clinic. Let them walk in.
That works. I mean, it's not difficult. It worked.
Actually, only in the first few visits, but once they start the hormone therapy, you can hardly make this distinction.
Actually, you can't even recognize. I mean, the patients cannot be recognized.
They completely, I just can't recognize.
Yeah.
So that's the beauty of hormone therapy,
Yes.
of how you transition them and the surgical procedures that they go through. So I think in the first 2 visits, maybe third, fourth visit, absolutely no difference. You can hardly say that this person is trans, right?
Yeah.
So
Yeah.
So how do we engage with the family members? So we are not talking much about the guidelines, because the guidelines are already there. You can download and read it. It's available everywhere. So we just thought of all these social issues which we come across when we start the practice. So we thought this would be more important than the guidelines part of it. But what do you do?
This is the most difficult part that I have encountered, engaging the family members. Initially,
So before we go to that, what is the percentage of your patients coming with family?
Family, now it has increased. Around 20-25% are coming with family is bringing them. many a times. Especially these days, trans men, parents are accompanying them. It's a good change, good social change that I'm seeing. Even that as these adolescents and all, they are bringing it up, bringing the kids.
I have a husband and a wife
Yes.
with a 16-year-old daughter, a teenage, almost my daughter's age. The wife brings the husband because the husband wants to transition to a she. So they both come in a
Exactly.
sari.
Uh-huh.
And the
Yeah.
daughter calls both
Mom.
as mom, right? So the wife is so supportive of this entire transition of her husband going through the
Exactly, I do have
therapy.
one patient.
I was like, it just took a while for me to get a grip of it, but when I started talking to them, it was.
But they have they know how it works. They are not planning to get separated or anything. They are happy with living like that. They have understood each other very well. So it's totally their decision. But this family members, yeah, it's difficult because first setting, many people have come and blamed me for doing this, like changing their son or daughter. But after a while, we offer family counseling sessions as well, and we have some support groups, family support groups among the parents who have gone through this. Few are they offered help to extend their conversations to other parents as well. So we have formed a small group. We give numbers. They are willing to give their numbers to other parents. They speak with each other. So family members, what I usually tell them is, after all, it's the same child that you have loved till now. Nothing has changed, only that gender, what they perceive, it's different. So, see, they will definitely do it. They are more than 18 years, they are going to change. Even if you support or not, they will definitely change. But they will be happier. They will be more happier if you are offering your support. And one thing is, what worries them is that many of them think that this illness is, mothers especially, they think that it is because of something that they have done. Many of them ask us, like, what, I had some tablet while I was pregnant, is it because of that my child is like this? So you have to mitigate all these guilt from the parents, and many think that it is their upbringing, the way we have raised this child, or peer group blaming is one important thing. So mitigate all these kind of guilt from parents and tell them it's the same child will be and another concern is, what will happen with all these hormones, the medicines they are taking, the surgeries they are undergoing, isn't it harmful to their child? That is another concern. So you have to tell them, explain to them, Mohan told, the biology, you explain to them, there is nothing, there is no disease in your child. Right. Yeah, so all these, and offer counseling, multiple sessions, but I have seen most of the parents coming around. Last week also one parent came and created a havoc in our hospital. It was such a...
But actually after 3-4 years, I have somebody who's transitioning for 10-11 years now. 3-4 years into the transition, they come back and thank you also.
Yes.
They said, ma'am, I've got my son or daughter back. Huh? They're doing so well in whatever they're supposed to do socially, like police officers, working in Amazon, wherever. They're doing much better,
Exactly, when they were non-transitioning.
When they were non-transition. So I've had parents who come back and thank also.
Definitely, a lot of them are there.
That's very rewarding actually
Yes.
in practice. So in the first conversation could be
it's
very
difficult.
challenging. But we also do have the Zoom parents group.
Oh, that's great.
Thanks to the Zoom thing, we do have consent and, they do share their experience. As you said, 20 to 30% is pretty good actually for family support. I would say 10 to 15% in my practice who come with their parents and sit and talk. But that's really
many
good.
people,
this is the most challenging part of.
Sometimes parents come to invite to their transitioned son or daughter's wedding. So that's a very good feeling too.
One of my couple live in Kerala now. I got invited for their wedding.
Great.
Yeah. So that's actually quite happy to see. So I think we'll move on to this last question. I think we'll stop with this and take questions. I'm not going to walk you through the guidelines, as I said. So what are the essential points of discussion around introducing hormone therapy? You already pointed out that parents are very concerned that we are harming their child.
Yes.
There is this myth around cancer. There's a lot of myth going around. So, what would you just tell them?
We see, one thing is that this is not a small process. I mean, one thing, multiple steps are involved in this. It involves not just me, a team of doctors. It doesn't like you have, and long-term follow-up. That is very important. First of all, I assure that these patients will continue follow-up, be it in Kerala or Chennai. We have people all around India. So wherever they go, we can refer to that appropriate person anywhere. And introducing to hormones, that first point will be the mental health clearance, which I always get it. After that, the investigations. We all follow the same protocol. So lab investigations will be done. If everything is okay, the comorbidities are well controlled, then we explain them about what we are going to do. Like what is your, the hormones that you have now, what are we going to do? Like suppress the endogenous hormones and give you the cross-sex hormones. And what these hormones are going to do to your body. That
Right.
changes. Timeline of changes is very important. We just explain that.
No overnight miracle.
Miracle is going to
I
happen.
usually start saying that I'm not a magician. I'm a doctor, so you have to,
Yes.
be patient and see the transition in X number of time.
And also that the side effects of that they can expect. I always tell them beforehand itself that like after starting testosterone they will get acne, definitely. So clitomegaly, suddenly they will be like scared when clitomegaly and all happens. Similarly, the alopecia, androgenic alopecia, they will lose their hair. So all these points, and trans women also explain all about probability of hyperprolactinemia, the breast pain that they can occur. Salt craving is one important thing that almost all my patients have told, salt craving on aldactone. So all these things we explain beforehand. And most importantly, I think fertility preservation.
Right. We didn't touch upon that.
Yeah, that conversation is very important before initiating any kind of treatment in your patient. Explain about, because it's not like 5 years back. Today we have all the facilities for doing fertility preservation. Sperm banking is very commonly done.
Yeah.
And even trans men, I think we have 5 patients who have done ovum, like embryo preservation with a donor sperm.
I have had patients who have started testosterone therapy and then we stopped it for 6 months, restored the ovulation, and then we did the...
Yeah, this patient, Mohan showed the photo, no? That was previously my patient, but later on lost to follow-up. They stopped hormones for this.
Right.
So
obviously otherwise
yeah. So all these then even contraception also, sometimes you may have to say even while on hormones there are chances they can get pregnant. So you have to explain that as well.
Safe sex.
Safe sex.
I think it's not easy. I'm sure we'll not be able to do all of these in the first visit. I think you prioritize your conversation, what you do in the first visit. It might take 3, 4, 5 visits, but it's okay. But we need to sort of go through these checklists.
I have a consent form which is in regional language as well. So while they are in the waiting room itself, my OPD staff will give these forms to them so that they can read it up.
Right.
So that they know what questions to be asked. So once they come into my room, they will be slightly prepared. They know what is going
that's
to be the conversations.
Yeah.
So I get I can
save some time.
Yeah, save some time over that.
I hear you. Yeah.
Then so
we'll finish off with this.
Yes.
Slide.
What
so
is
I
your
think there's a whole range of improvement in psychosocial measures. I have told a lot of parents have thanked us who actually were not very happy with us at the beginning for what we have, how we have helped them. Not all transgender seek all interventions. So some may seek none at all. And it's important for us to understand that it's okay and you have to treat, what they want and how, what sort of doses we use and everything. So in the past practices were having a pathway of psychological assessment, hormones and genital surgery. Now it's no longer there. The current standard of care is allow each transgender person to seek only those interventions which they desire to affirm their own gender identity. And we don't have to throw all of these treatment modalities in all our patients.
What's your overall experience in one word or two?
I mean,
what would you
I would say sometimes it's draining. I'm not going to be here sitting here and say this is it takes a lot of effort and time, and it doesn't really give me a good compensation as well for what I'm doing in a private practice. I'll be very honest with you in that as well. But some days it just makes me sleep better that I have helped somebody, I've helped somebody. I mean, it's sort of a mixed feeling. I wouldn't say like this is...
Exactly, mixed feeling. Maybe overall I have become a better person because of that.
I agree with
at the end of the day.
So that's exactly where I'm going to finish this. Is 2 important days in your life are the days you're born and the day you find out why. And I think that's probably what she touched upon, saying that, yes, it just makes you think the second point of what Mark Twain said. Thank you.
Thank you.